So today we are going to discuss the support group aspect of bariatric surgery process. And support group is important not just prior to the surgery, but it's even more important perhaps after the surgery, because there will be a little bit less availability. I'm saying less, but that's just compared to the prior to the surgery, obviously. So Dr. Gao, if we can actually just give the background on support group and why we are doing it and how we can actually help people to better understand and better utilize the Surgery Center, American Surgery Center support group from our patient's point.
Absolutely. Support group sessions are very important after bariatric surgery, Kamal. To just relate on the importance of this, let me just talk to you about a case I did on an emergency basis this morning at the hospital. So a patient showed up with evidence of bowel blockage after gastric bypass. That is something that can happen. We know, of course, and we're here to take care of that. But what struck me about this situation, Kamal, is that this patient had gastric bypass in 2008 at the University of Pennsylvania. Very good place, very reputable bariatric center. But it's the disconnect between, her surgery and then the follow-up. She hasn't had any follow-up for really many years since then. And that is problematic. That's problematic because a bariatric patient should be a patient for life with their bariatric surgeon. Clearly, it is possible for people to move geographically afterwards, but it's important that they connect with bariatric surgeons in their area. And our bariatric center, of course, is here for our patients, but we're here also for any bariatric patient that may be needing follow-up afterwards because they have moved to our area. Because this patient has not had sustained follow-up and, of course, possibility to do support group sessions like the one we're going to talk about today, Kamal, this patient had regained considerable weight and has not been able to really get any help on how to get back to basics and to seek help, right? Importantly, there is no clear information about her vitamin intake or the vitamin level after gastric bypass, which, as we've said in many sessions in the past, Kamal, it is critical for patients who had gastric bypass to have an ongoing check on their vitamin levels, that they have to continue taking vitamins. So
we do cover that in our one of our regular episodes on a regular basis.
Absolutely, absolutely. So the importance of ongoing support in the form of support groups that we're talking about right now and follow-up with the surgeons is really important for long-term follow-up of our patients, right? So not only we're talking about weight loss that has to be sustained for life, we want patients to become healthier from their weight point of view for the rest of their life. But there may be issues and problems related to their surgery that can come up in the long term. And if there is no ongoing follow-up, that is not going to happen, right? So what is so specific about the support group? Well, a support group is a periodic meeting, and ours happens once a month on the first Tuesday of every month. And nowadays, thanks to Zoom, it's a virtual meeting, so patients can attend to it, wherever they are. But what is important is obviously we raise topics that are relevant and pertinent to the patients, right? What kind of vitamins am I supposed to be taking, right? What happens if I have excess skin after I lose weight? What happens if I start struggling with snacking again? That is a threat to my sustained weight loss. What happens if I have issues with self-image, for instance? I am having a hard time seeing myself again as a thin person. What happens if I have anxiety about my relationship with others because of my weight loss? What happens if me losing weight is a threat to my relationship with others? These are important issues that can affect any of our patients, and discussing them in a group session, with one of us leading that, is actually liberating for the patients, but also it frees them from, some difficulties about bringing out these issues. And when they come to the support groups, they can be just listening all the time without saying any words. They can be actively participating in, or they can be asking questions. So the gamut is wide. And as I said, because of the virtual setting right now, people, even if they have reservations about their privacy, they can just, turn off their camera or mute themselves and just listen. And that by itself is also immensely helpful. Because very often the other side of the issue, Kamal, is that when patients struggle, for instance, with weight regain or, snacking, they may be afraid about bringing up those issues, or they may feel ashamed about bringing those issues, right? But when they see that there are others also who are struggling with the same type of issues, then they may feel much more comfortable about bringing those issues. So bringing those issues, discussing them as a group, and then finding solutions and implementing the solutions can resolve many of the problems with which patients struggle. Okay, so what we're saying essentially is that bariatric surgery is different from other surgeries, different from gallbladder surgery, different from hysterectomy, where you have a single encounter with your surgeon or your surgical practice, and then you move on to your life. With bariatric surgery, because of the changes that we undertake on the digestive system, an ongoing follow-up is important, and part of that follow-up is the support group setting that we think is so important that we are dedicating a whole session about it today, of course.
So now, thank you, Dr. Gat, and you are absolutely right. So there are ways to communicate the issues, because there are a lot of different things that are happening with this process of the surgery and what also is happening after the surgery. I think one big part of it is, as much as our Tuesday sessions are helpful for that once a month with the surgeon being there, but we also have a Facebook support group.
Yes.
And I do want to spend a little bit of time on that. So what I see, and you and I, we are checking those on a regular basis, and our team is looking at that. There is this, not just, it doesn't have to be an issue. People want to share what they're going through. They want other people to know what they're about to do. When they start, like I read one of them saying that I'm on the second week of Robart diet and super excited about getting healthier and enjoying hiking like I used to. So, well, there's no problem here, right? But it's in the support group, because we only, we do much better when we are able to share these. It doesn't have to be just a problem. So when, of course, for those who are also following us, I do want to remind them to be mindful of the support groups, because this is not a platform to make individual complaints about difficulties that they may be experiencing, not related to the surgery itself, but just because they called offset and no one answered. That's not the support group is for. This is a place for specifically for the actual, like anything that's involved with the surgery and after surgery, and how you went over the challenge of doing the Robart diet, if it's for 3 weeks, rather than complaining about, oh my God, I have to do Robart for 3 weeks. Well, the only reason someone may need to do Robart for 3 weeks, we explain them, right? But it's not a place to complain about that. Right. Because if your BMI is over 60, chances are you are going to do 3 weeks diet, because we want your surgery to be less problematic, because you need to reduce the liver, the fat around the liver, right? So it's not because we want surgery, but that's not. You can say that third week is tough, but if it goes into oh my God, why do I have to? That's not a place, because we have to respect everyone else. But I was trying to actually just point out most of the messages that I read there is they just want to share what they're going through. that's nice. But also when we see questions, then we are also able to address those, and then we are able to cover those on the surgeon led specific session. So I think between the two, having the Zoom event and also having the specific page, there's enough resources available for the patients.
One of the really neat things about meeting with a dietitian is we work with where you are as a person. So I don't expect every single one of my patients to be able to do the exact same thing on the same time frame. We're going to cater and work with you for what things are difficult for you and what things come easier for you. So, for example, you were saying to me how tired you are with exercise and things like that. Well, of course, because you're carrying a lot of weight, that makes things hard. Plus, you have the apnea, etc. So I need to know all of these things so that at the end of the session, when we start setting goals, I know how to set goals for you based on what you've told me. Like the reason I asked you, who cooks in the house? Well, you're not the main cook. You're not the main shopper. So I know I need to counsel you a bit about how do you broach that subject? Because even if you're making nutritious changes after surgery, if the cook doesn't get the kinds of food and prepare the kinds of foods that are going to help make you successful, that's a roadblock. And it can get complex because I need to know about some of the family dynamics. Do you have a lot of support for this change? Or are there people in the household that are saying, hey, Kamal, you can do what you want, but don't make it affect me? And dietitians, we get into that because we want to set you up for success. So I might have to counsel you on how can you go past those kinds of roadblocks. Okay, so I just want to let you know why I talked about those things.
Absolutely, and I think I see what the point here is that in some cases, when I want to be on a certain diet, then it's not supported. So that if they are not doing it, if they eat, then you feel like you are left out, and you're already struggling and hungry, and I don't think there's enough support or maybe enough understanding of why I decided on the bariatric surgery kind of.
Right.
Because they should maybe have the same process, but they don't want to do it.
Right.
They think that I'm picking the easier way to figure out the solution for a problem. But I say, well, this is the most effective way. Then why would I not take advantage of this? Because I tried all the diets and everything, but then they don't agree. The family does not agree with the surgery.
So as a dietitian, I'm going to kind of work with you based on what your family situation is. And I'm going to tailor and tailor my feedback, tailor my recommendations based on that situation. All right. Now we're going back to our role play. Okay. So get ready again. All right. So
we were all role playing. Everything that I told you was about role playing. Right? So.
Well, it kind of was, but we were also explaining. All right. So one of the things that's important for this session is I need to get an idea of how your day flows with food, because how our day flows with food tends to affect our health outcomes. So again, remember I told you I'm not here to be the food nanny. So I want to hear everything. I want to hear about the healthy stuff, the unhealthy stuff, so that I get a good picture of things. And keep in mind, dietitians, we love details. So instead of telling me for breakfast you have eggs and toast, tell me please, I have 2 slices of white bread and I have usually 1 or 2 scrambled eggs and 2 slices of turkey bacon. Go into a little of the detail for me.
So, I would say that on a weekday, I think bread is part of the issue. I would say, and sometimes I don't know when to stop. Like I don't feel like I'm full, so then then I realize later on that I'm I ate too much, and that already sets off the day in the wrong way. And then Usually it's eggs and maybe cheese and some sweet stuff like the cereal. Like again, the portion is the problem.
Mm-hmm.
And you want to, it says there's serving it's like 1 cup or like whatever. So then I may end up having 3-4 cups.
Mm-hmm.
So, and I don't realize sometimes I do that. And that's usually how the breakfast goes.
Okay. So typically you're choosing between maybe 2 kinds of typical breakfasts, a lot of cereal or maybe like eggs and cheese.
Mm-hmm.
Would you have anything else with the eggs and cheese, or usually that's just it? Would you have like toast or bagel?
I would have like a couple slices of bread. Like I say a couple, maybe more than a couple.
Okay. And typically is it usually white bread, wheat bread?
Regular white bread.
Okay. What do you like to put on it?
Like butter.
Okay. All right.
Butter with salt. Black pepper.
Cereals. What kinds of cereals do you often have?
Well, I like the ones kind of like the chocolate flavor ones, like they're kind of like little,
like Cocoa Puffs or something like that.
Yeah.
Okay.
So I actually really don't know what's out there.
What kind of milk do you tend to use?
Regular.
Like a whole milk?
Yeah.
Got it. Okay. All right. Thanks. What about anything to drink in the morning?
I would probably have some coffee or some days maybe tea, but mostly coffee.
What do you put in your coffee?
Creamer and a lot of sugar.
Okay. All right. So do you use the packets or like a spoon for the sugar?
I use a spoon.
Okay. How many do you tend to put in?
Like maybe 2.
Okay. All right. The creamer, is it the regular creamer or sugar-free creamer?
You want to see what this?
Yeah, if you have it, that's great. Yeah. Okay. Okay. Yeah, it looks like an International Delight maybe or something like that.
You see it?
Kind of. It's a little fuzzy, but I can get a general idea. Okay.
It's Coffee Mate.
Coffee Mate. Got it. Okay. All right. All right. All right. So kind of got breakfast. Do you tend to have anything you like to snack on between breakfast and lunch, or do you tend to eat a bigger breakfast and wait till lunch?
Breakfast and lunch, no. But usually I have snacks in the afternoon. Like I get a little bit like more tired, and then I would probably like want to have some ice cream or some chocolate bar or something.
So you might have that mid morning, or is that what you said?
This is more in the afternoon, like after lunch.
Afternoon. Okay, got it. Okay, all right. So what kinds of things? So you said after lunch. So what kinds of things do you like to have for lunch?
Usually, like the fast food.
Mm-hmm. Okay.
McDonald's, Chick-fil-A, Burger King.
Okay.
I don't pack lunch, so then we end up buying usually.
Okay. All right. So we did talk about kind of typical snacks that you might have sometime after lunch. Dinners. Do you tend to eat mostly dinners from home, or do you tend to go get takeout? I want to know kind of the ratio of like.
Mostly home cook. Like a lot of probably steak, chicken with rice, regular rice.
Mm-hmm.
Sometimes pasta with it. So
Okay.
not a lot of salad. And usually I want to have usually like some dessert after dinner.
Okay. All right.
So far.
So let me see if I've got this. So typically when you're eating the dinner that somebody else has prepared, because you told me somebody else is usually cooking,
Mm-hmm.
There's always usually some sort of protein on your plate. So it's some sort of meat usually. Would you say, how do they you prepare it usually? Do they bake it, fry it, barbecue?
Summertime is less fried stuff. Like there's some like maybe barbecue type, but outside of summer usually fried.
Okay, all right. So, and then you also said you had some sort of carbohydrate like rice or pasta. Do you ever have potatoes or anything like that?
Yeah. Some days with, and also like some other vegetables like eggplant and zucchini.
Okay. So that was one of my questions. Is there usually some sort of vegetable with those things, or sometimes yes, sometimes no?
Sometimes yes, sometimes no.
Okay. All right. Got it. All right, thank you. Because all of that is really helpful information for me as a dietitian, because we're going to be kind of talking about what things you're doing well already that are going to help you after surgery, and you can keep doing them. But we're also going to look at some of the things that you might need to work on changing a little bit or a lot to help with your health goals after surgery. But again, I'll go into that mostly in our second session a little bit. We might touch on a little of that at the end of today's session. Okay. All right. I do want to find out what you drink besides that coffee that you mentioned. What do you drink throughout the day?
Rest of the day, I would probably like between coffee and sometimes I get Starbucks, the latte. If I do Starbucks, I would get some sweet snack with it. In some days, maybe just tea. But between the coffee and tea, alternate.
It's all right. You said besides the coffee and the tea, what did you say?
Coffee and tea,
Okay.
just the regular tea.
Okay.
Some days maybe like a Diet Coke I would have. So that's
Okay.
that's the other thing.
All right. I'm gonna just kind of brainstorm some other common drinks, and you can tell me, oh yeah, I also have that, or no, I don't. So any water.
So I because I started going through the first consult, my surgeon told me to pay attention to the water consumption. So I try to increase it. So I usually finish like 2 of these.
Okay, that looks like about 24 ounce maybe, or okay, maybe. All right.
More than 20.
Is it?
Let's go with 24.
24,
And
32.
to make it a little bit more enjoyable, I put in the middle of it. I don't know if other patients would like to do this.
Lemon.
I have lemon, cucumber, ginger, and mint.
And I'm glad you already know about that. Good, because I often have to tell or explain that that's an option. We call that infusing our drink, and it's a way to get lots and lots of healthy water, which is absolutely kind of one of the cornerstones of being healthy. But you don't have to always drink just completely plain. So you're right, doing something like that is a great idea, and you can even do something like that after surgery too. So any like lemonades, punches, anything like that on a regular basis, or not really?
No, like if in the evenings, I would probably have a couple glasses of wine.
Okay. Okay, good. Yeah, and that was going to be my next question: is any alcoholic beverages? So wine, a couple glasses, would that be most days of the week, or would that be maybe 1 or 2 days?
Probably like every other day-ish. Not every day, but maybe like 3-4 times a week. Okay,
great. All right, I'm pausing here again. I'm going to make a comment now. All right, so I'm on the other side here. All right, so the reason we went through all of that is at the end of my session today, if I have time left, I am going to start to have them kind of work on some of the things that patients are doing that will need to change in order for them to be really healthy after surgery. And we won't try to tackle everything at once. But for example, one of the things we might look at is, are they getting any sugar in their beverages? We might start to work on the sugar in the coffee. We would also work on, I would talk with them about caffeine consumption, how you need to start to wean before surgery from that. We would talk about ways to get their water intake up. And then I would be talking about alcohol, how to kind of pull back on that. And then I'd talk about kind of the guidelines around alcohol and bariatric surgery, because if people do like alcohol, they usually want to know, can I ever have that again in my life? So we do touch on that. Anyway, so all of those details are going to help me to tell them what they're doing really well and work with what is not going to help with their healthy weight loss after surgery. Okay.
kind of see it from different ways. And when we say risk and complications, so the definition of risk is a situation involving exposure to danger or expose to danger, harm, or loss. So when you come from that angle, it's a little bit different, because like I struggled with this one a little bit, Dr. Gao, and I'll tell you why. So when I look at the risk and complications, I know we want to talk about surgery risk and complications, but the not doing the surgery risk and complications is maybe a lot heavier, not a lot heavier, much more heavier. So that's something that I wanted our patients to really understand. So yes, we are going to talk about the surgical risk and complications, immediate one, midterm, and then long term. But not doing the surgery has a bigger risk, and which we discussed the benefit of bariatric surgery. And this is something that I wanted to make sure that we kind of like highlight and emphasize for people who are following us.
That's actually a great way to frame this discussion, Kamal. Very, very important. You're absolutely right. Risks and complications are things that can happen, during a particular intervention or treatment, right? But the treatment is essentially a choice, a decision, right? And not taking the treatment is also a decision and a choice, right? And then we have to look where each of those roads lead the person, right? Where does a person end up after they have surgery and lose weight, right? What are the risks within that road? And where does a person end up if they don't have surgery and continue in the course of morbid obesity? Where does that road lead them? What are the dangers that are facing them, right? Well, let's look at the most striking danger, which is death, right? That's what we fear about surgery, treatment, right? Is there a risk of dying, right? Well, with any option that we make, with any treatment, obviously that possibility is there. It's never zero, come out, right? But if you look at bariatric surgery, the way it has been refined, the way it has been prepared in modern programs like ours, modern programs that have been certified as centers of excellence with very experienced surgeons, the risk of death is way lower than 1%, right? Lower than 0.1%, right? Now, compare that with the risk of shortening one's life if a person was continue to stay morbidly obese, right? We know that with morbid obesity, all the data show it come out clearly, a person's life is cut short. A person is less likely to achieve their life expectancy, right? If they stay morbidly obese. The higher the body mass index, the shorter the lifespan. So there is no question there. It's not about a 1% issue. It's a 100% issue, right? If you stay morbidly obese, you are not going to be living the way you are expected to be living compared to the life expectancy in our society right now, right? That is that. So when you have these stark figures, you know that the choice should be really clear, which is losing weight with surgery is far more beneficial, much less risky than staying morbidly obese, right? Having said that, it is obviously very important that we educate our patients about the possible risks of surgery. We have that obligation as healthcare givers that every time that we provide a treatment, every time that we recommend a treatment, we have to be able to inform, educate our patients the benefits and the risks. And that is obviously the session today. We will be talking about that. Now, as you correctly said, risks and complications are very different from consequences, right? So a risk, for instance, could be bleeding or blood clots, as we will speak, right? But a consequence might be excess skin, for instance, right? Losing weight, that's a known consequence of the surgery, right? If you're losing 100 pounds, you will have excess skin. That is not a complication of the surgery. That's a consequence of the surgery because of what it does, you lose weight, right? A complication is something very different. We're very happy, obviously, to report that in the way we perform bariatric surgery right now, the risks are very low, particularly the serious life-threatening risks are extremely low. And that is because we focus on prevention so well. And we've been very, very successful in preventing these serious complications in the vast majority of patients. Nevertheless, of course, today's session, we will be discussing them.
Absolutely. So that actually, again, because we do these in smaller sessions, shorter sessions, so that it's not the entire process that we are discussing. But even for us, maybe this is our fourth or fifth time we are maybe repeating the same topic. However, the way that we are processing, it still brings up those unanswered questions, or maybe not addressed concerns, because when I was maybe preparing for this, I'm seeing it differently than the patient standpoint. I'm like, well, I'm talking about risk, but then, well, when they have to live with BMI 60, first of all, they're not going to live that long. So then that's why I was kind of like just having my own debate there. So then I wanted to share that with you and with our audience. Now, going back to the risk and complications, so if you can actually let us know what are the immediate risks from the surgery, and then we'll continue from there.
Absolutely. So it is important to talk about the immediate risks of surgery. Immediate meaning things that can happen, within the first 30 days or first 45 days after the surgery, right? So I want to focus first on the potentially serious complications, the complications that could be potentially life-threatening, okay? And really, there are three major complications that can happen with any type of major bariatric surgery, right? The bariatric procedures that we do right now include gastric bypass, gastric sleeve, duodenal switch, and to a less extent, the gastric band as well. And to some extent, the complications that I am going to talk about right now can happen to any one of them, although they may be much more pertinent to gastric bypass, gastric sleeve, and duodenal switch, as opposed to the gastric band. So the first one is infection, okay? Infection, what type of infection? Internal infection. We're not talking about superficial wound infection. We're talking about internal infection. Again, this is extremely rare nowadays, right? And it happens, or it can happen, if there is something called a leak, Kamal. And we've talked about a leak, and patients talk about a leak, but it's important to make sure people understand what this means, essentially. Essentially, when you do gastrointestinal surgery, the way we do it for bariatric surgery, you are cutting the stomach or the intestine, you are stapling the stomach or the intestine, and you are connecting together the stomach and the intestine to some variability, right? When you make this cutting and this connections, the wounds have to seal with complete integrity. In other words, we cannot have even a bubble of air go through that wound. With that complete sealing of the wound and integrity, there is no problem. But what if there is a leak? What if there is loss of integrity of that healing? Substances that are supposed to stay inside will start leaking out. And a good way to understand it, to have an analogy, Kamal, is to think about the pipe system in a house, for instance, right? We have pipe systems running around inside the walls of the house. Something enters at one end and it's supposed to get out at one specific end. You don't want the pipe to have any defects in the middle, because if it does, then stuff will leak out, right? It's the same thing with our digestive tract. It's one long pipe that starts from one end and finishes at another, right? Stuff goes into one end and then gets out from the end.
Mm-hmm.
It's sealed that way. There is nothing that should be leaking. If it does leak, then you will have gastric juices, acids, bacteria leaking out and creating an infection, right? This is what a leak is essentially, right? And it is extremely rare nowadays with the way we do surgery, Kamal. It's less than 0.1% in our practice, right?
I was going to say that. So I don't, since 2001, I don't actually, 2021, I don't see any.
None, you're absolutely right. That's a very, very few in between. Now, there is different extents of this, obviously leading to different outcomes. Of course, it is a serious condition. There is no question about that. But early identification and early treatment leads to a good outcome, right? And one of the things we do is we educate our patients on telling us if they're not feeling well or doing well, because there are signs of a leakage, right? What are the signs of a leakage? Well, the patient, first of all, are not going to feel well in general. They're going to feel sick. They may have nausea and vomiting. They may have a fever, right? They may have chills. They may have abdominal pain. When any of those things happen, they need to let us know, because this could be the indications that the leak is happening. And what do we do? Well, we bring them in, okay? We provide them antibiotics, and we do tests to see if there is a leak. And if there is a leak, sometimes the treatment might be just avoiding food, right, for a while, and giving nutrients through an IV and antibiotics, and that will actually seal by itself. Sometimes we have to intervene by placing a drain or doing surgery. But even though it is a serious condition, it is fixable as well. That's the other thing that is very important to understand. We have to educate our patients about possible signs of this so they can alert us in time. The worst thing that can happen is for this to drop on without anybody intervening, right? So leak, something that can happen with any of these major procedures. It's extremely rare, but it can be serious. It's preventable with the way we do surgery, but also it is eminently treatable.